Well, welcome back. And today we're going to just show the written slides that accompany our talk on refractory chronic migraine. I'm going to run through these fairly quickly, and you can watch the attached video that's on this channel that is our talk on refractory chronic migraine. Now, chronic migraine is a few percent of the population, which is millions of people, and we've gone through different definitions for refractory chronic migraine over the years. But basically, prevention medicines cannot have helped, and we base refractory based on how well prevention medicines help or don't help. There's a lot of questions and challenges with refractory chronic migraine, the definition, which we've been working on for decades. How much does disability in the person matter? Are there biomarkers or chemicals in the bloodstream or spinal fluid that we can tell, or scans, such as types of MRI or PET scans? And does it help to separate into mild, moderate, and severe refractory migraine? Refractory migraine can change where it goes back to episodic headache and all of a sudden is not so refractory, where medications are working. And of course, we treat headaches differently at different ages. Medication overuse complicates everything, and the diagnosis of medication overuse is very debatable. One question is how the headaches come about. Does it matter how we treat them? New daily persistent headache, where they come about over 24 hours or so, or people are hit on the head and it's post-traumatic headache. Does this change our treatment versus what we call transformed migraine, where it happens slowly over years? Pathophysiology means what's really causing the headache in the brain, and it comes down to genetics mostly. We get what we call central sensitization, where the brain is just firing on its own. And there are changes in the brain with refractory chronic migraine, where you can see on certain scans changes in the white matter in the brain. Does medication overuse headache change the brain? And how much do psychiatric comorbidities such as anxiety, depression, bipolar, personality disorders, how much do you see in the brain as far as changes in gray and white matter with those? One question is it useful to have a scale of mild, moderate, and severe? I published on this in the Journal of Headache and Pain several years ago, and that's actually an open access journal. If you Google Journal of Headache and Pain from Europe, it's actually from Italy. It's the European Headache Society, their journal. And we published on separating into mild and more moderate or severe refractory categories to see. I think that for research this helps, but clinically it also can help. Medication overuse headache, as I mentioned, is complicated. It does contribute, and the official definition of the International Headache Society is not all that accurate. You just need a certain number of days of taking painkillers or over-the-counters. But I think it's more complicated than this. That would be medication overuse, MO. But to diagnose medication overuse headache, we really need to tell if the medication and the overuse of it is causing the headache, which is much more complicated. Now, outside of medicine, we do want to minimize medicine, so it takes a village to raise a pain patient. It also takes a village to help somebody with severe psychiatric problems, and so we get other villagers. We'll use physical therapy or psychotherapy, whichever is appropriate, massage, acupuncture. We always encourage exercise. People get the most exercise benefits in the first 20 minutes a day. So 20 minutes a day on average, people get 80–90% of the benefits of exercise. We're going for at least 15 or 20 minutes a day, walking, treadmill, bike, anything. The core work, Pilates and yoga can help. Meditation is always a mainstay, and they teach it easier these days. Instead of an hour or 2 hours, you can do 10 minutes of meditation. It can help. and biofeedback, which is more of a formal program. Catastrophizing is where people are always thinking it's a 12 on a scale of 1 to 10. Everything is horrible, the world is ending, and we try to dial down the catastrophizing dial. Sometimes we see what we call catastrophizing by proxy, where a parent says, how can a 16-year-old possibly have headaches like this? And we try to calm things down. Resilience is very complicated, and I go into resilience more on our formal lecture on this channel, but it involves genetics, the short arm versus the long arm of the serotonin transporter gene. There was a wonderful article on resilience in the New York Times a number of years ago called A Question of Resilience, but you can go on the New York Times website and Google it and search for it, and it was just a terrific article on resilience in people. A lot goes into being resilient, but we're always trying to improve resilience, which is not easy to do. Acceptance. People generally will not accept chronic pain or chronic headaches when they just start, so they may go to 100 different clinics looking for the aha moment, which rarely comes. And sometimes we see lack of acceptance by parents, by proxy. Coping, we're always trying to promote active coping, which is not just sitting around saying, doctor, give me enough drugs, and when you do, I'll get out of bed and go back to work. We need people to volunteer, work, exercise, do things. A second about the caretakers, it's very difficult for spouses or parents or kids of somebody with severe pain or severe headaches, and there's a certain amount of depression sometimes. It's a tough position. We do see some all-star spouses and parents, but more often people around the person don't want to hear it after a while. Unfortunately, people with headaches tend to be shunted aside, and at work, nobody wants to hear it, so the best we can do is try to help their headaches. Headache doctors also have a high rate of burnout, and I coach residents and doctors in a number of ways to try to reduce burnout. Now, there's a number of good outpatient therapy options. There's no good algorithm because every patient is unique. If you have 100 different headache patients that are refractory or difficult to treat, you go 100 different ways. We look at the headache history and the medication history. We look at all the comorbidities, psych, medical, their sleeping and their GI system. Do they have diarrhea or constipation or IBS, GERD? Weight gain is a big problem, so is that an issue? Fatigue. Do they have neck and back and arthritis pain? What's their job or school requirements? For instance, if people have heavy-duty job requirements, they're an accountant, or a physicist or a chemistry teacher, we don't want to push Topamax to higher doses because it can make them very spacey. Addiction histories are important if we're thinking of using anything that could possibly be addicting. And finances. I don't want to push a therapy on somebody that I know can't afford it. The family history of responses and family history of psychiatric and medical comorbidities is also very important. In the end, we run this all through our brain, our computer brain, and using our Gestalt, hopefully we come up with a good plan. So the top 10 medicines for one person is much different than for the next person. Botox is a very good treatment for many people. It works for 60% of people long term. And there's new studies that show that the more Botox people get, if they get it 3, 4, 5, 6, 7, 8 times, they're more likely to revert to episodic headaches or not chronic anymore. It's FDA indicated. In fact, it's the only thing that's FDA indicated as a prevention for chronic migraine. And there's several ways to do it. Either the FDA protocol, which is 31 shots around the head, or lower amounts chasing the pain. We've done Botox for about 20 years, and we do it all kinds of different ways. Off-label, we've used Botox for cluster, TMJ. Many people have used it in adolescence. We've had some good success, and it probably works through the neuroimmune response. I started looking at the immune system in headache in 1987. We did some studies on helper suppressor cells, and I was convinced that it was a key in headache. We actually found the opposite to AIDS, where instead of lower helper to suppressors, we found higher helper to suppressors in headache patients. And indeed, when people do get AIDS, it changes their headaches. Now, they get headaches for other reasons when they get the clinical syndrome of AIDS, which thankfully is much less these days because of the successful medicines. Polypharmacy is another way to go, and that means using 2 or more preventives. Comorbidities like the medical, psychiatric, insomnia drive where we go with these medicines. Weight gain and fatigue are big concerns. Sometimes we use Botox with another preventive or even a natural preventive such as Patatilex. SPG blocks for frontal pain. They've been around since 1914, but they're much easier to use now because of these newer devices. And we squirt some Novocaine basically up the nose, and it blocks the SPG, which is a collection of nerve cells in the front. And sometimes it really helps chronic migraine where nothing else has. It's very safe. So it's always a consideration now. Back of the head blocks, occipital nerve blocks, and trigger point injections are useful. They do hurt. They do only last a week or 2 or 3 if they do help. Sometimes they can stop a cycle. Occasionally adding in steroids will help, but usually we just use the Marcaine, a Novocaine type medication. Frequent triptans, many people lapse into daily triptans or frequent triptans. Years ago I did a study of 118 people where we used daily triptans or frequent, and while medication overuse is a concern, over the 25 years these look safer and safer, and sometimes they are the only remedy that helps. What we try to do is minimize the medicine. We use the kinder, gentler triptans such as Naratriptan and Frovo, which is now generic, and we can always use preventives with these. Opioids are a huge controversial area in treating chronic pain and chronic headaches. For a tiny subset of refractory patients, they may help long term. There are a lot of concerns with them, and now with the media exposure slamming opioids and the opioid epidemic, it's tougher and tougher for patients to find doctors to prescribe. But there is a small group who does very well. My general rules for success: no personality disorders, non-addictive personalities, not using them in younger patients. We don't want to be the first to put people on opioids, but once they're on them for 6 months or a year, their brain is sensitized and it's tough to get off sometimes. If they do well on short-acting opioids, we can switch to the long-acting. The key is no tolerance to the pain-killing analgesic effects. Most people do get tolerant. And recently, and I believe this week, the journal Nature or Science, there was a groundbreaking study on who gets tolerant, and it may have been a study in animals, but they believe that they've been able to identify a protein or a substance in the brain and bloodstream that will identify who's tolerant and why they're tolerant versus not. And I think this may lead to using better drugs. It is amazing that in 2,000 years we are still using the same morphine-based drugs. We need better painkillers that have less side effects, less tiredness, less constipation, and are not addicting. The companies have tried. There's been billion-dollar labs, Merck and Glaxo, working on better pain medicines, and they just did not work out. Stimulants occasionally help, which are used for ADD, ADHD. Sometimes they help tiredness and fatigue and weight, and sometimes they help the headache. In the right person, stimulants can be remarkably helpful without causing the usual tiredness and weight gain. The idea is to use low doses as we want to use with opioids. And there's basically 2 classes, the Ritalin type and the Adderall type. So some people do better with one versus another. But again, in younger patients, we're very careful with these. MAO inhibitors used to be used quite a bit. It's a class of depression medicine that was used in the 1980s. A lot, the medication phenelzine or Nardil we used, and now we're using more of the patch, the MSAM patch, but they're probably underused. For some patients, MAO inhibitors are the only medication that helps their headaches or depression. I still use the older one, the phenelzine, but the NSAM patch, selegiline, is actually safer and easier, and we've had some good success with it. You do have to watch your diet with these somewhat, but they are actually much safer than what was always talked about. There are a number of other miscellaneous approaches. Methergine is difficult to obtain and it's expensive, but occasionally it will help for a month or two. There's an Alzheimer's mild dementia medicine called memantine or Namenda that occasionally helps. It's called an NMDA antagonist, which has a number of properties, and it can also help memory. Muscle relaxants sometimes will help, and we'll use the non-addicting ones. And there now is out this TMS, transcranial magnetic stimulation device. There's a unit for home use. The big unit that is in offices is for depression. The home unit is for headaches. We don't know the true statistics of how many people will be helped, but I guesstimate 30 to 42% of the more refractory patients probably will be helped long term with TMS. It costs about $170 to $250 per month. You can get the cost down, and I think that it's relatively safe. We don't absolutely know long-term side effects, but the bigger TMS machine gives thousands of pulses, and this only gives a single one. So I don't think that we're going to encounter long-term side effects, but I will be recommending stopping it here and there because of that. Ketamine has been used intravenously, more for depression, but sometimes for pain, and I think it can be helpful, but there's a lot of side effects. The nasal spray, which we do in the office, is milder. We've had some good success for refractory difficult depression, a little less for headaches, but I think ketamine, if you use it judiciously in low doses, is fairly safe. And there is neuromodulation, neurostimulation, where they implant leads and wires under the skin, and there's a battery pack. Some people do well with this long term. More often people need it taken out, or it doesn't work, or they have some complication, but for some people it has been useful. Another one coming along is the ATI SPG implant, which doesn't have any leads and wires. I think that's more promising. They've had over 400 patients in Europe and had reasonably good success. Migraine surgery, where they cut into muscles in the front or back, is still early. There's no studies that I believe have been very well done. We can't recommend it at this time. And what's coming is CGRP antagonists, which are called monoclonal antibodies, where people have a shot once a month or every 2 months or so, and it prevents headaches. I think that the effect will be reasonable in some people, but people are getting their hopes up about these drugs, and in the studies, the effect is better than placebo, but it's not a miracle. I think I'll wrap it up here, and we're going to have other lectures, including soon we'll put one on bipolar and personality disorders. Thank you.